we're going to do a CPC today. We have a couple of interesting cases to go over. So Dave is going to start with the clinical history and then I will go over the path.
Hello, good to see you all. Thanks for coming out and everything in person and on Zoom. So we're actually going to go through two cases today, which is not typical for us, but these were cases that came in relatively close to each other that have some themes anyway that we'll talk about as through lines. So we're going to try to get through both of them. I will talk about the clinical course and biomarker data that was collected on both of these cases, and then Vanessa will go over the neuropathology for these. So the first case, this was a 66-year-old woman who enrolled into the ADRC's longitudinal study after a couple of years of progressive behavioral changes. About 2 years before her enrollment in the study, the family had noticed a lot of personality changes, lack of a filter in public, saying inappropriate things to strangers, more irritable, disinhibited, just inappropriate comments largely. She was becoming more apathetic, it sounds like, needing prompting for basic cleanliness, things like grooming her hair, lack of empathy, and inappropriate laughing at certain times as well. Sad stories that she would inappropriately laugh about. Unfortunately, she had fallen prey to several credit card scams as well. And independent of that, also started spending a lot of money. This is to the multiple tens of thousands of dollars. Fairly rapidly over a 2-month period, and this prompted an intervention of sorts with the family where they took away her credit cards and had to acutely give up managing her own finances. On a family trip, she was known to be driving very aggressively and was also sort of intervened upon and had to give up driving fairly quickly as well. She developed a new taste for fast foods, which was uncharacteristic for her, and subsequently gained more than 20 pounds over the course of a year. She had developed these paranoia and sort of delusions, feeling that there were people, neighbors that were listening to conversations, that there were people in the upstairs that were sort of watching them. This really wasn't a really like well-formed visual hallucination, more this perception that people were, out to get her or watching her. Unfortunately, this was, of course, incredibly disruptive, and she was let go from her job as a renal dietitian because of all of these changes. Couple of pertinent negatives. There didn't seem to be major memory deficits. She was able to recall recent events. There were no perturbations in language. She was quite fluent, it sounds like. There was no tremor that was noted and no changes in balance or gait initially. She was independent. She was able to do dressing, bathing, grooming, but needed prompting for all of these things. It could go multiple days without showering unless the family really forced her to. And her given every average day, she would spend most of her day on the couch playing on her phone. Anyway, lots of app-based games like Candy Crush, it sounded like. So this was her initial MoCA, which is maybe a little small for the guys in the audience, but she showed some deficits on trails. There were some deficits also on definitely attention and calculations, a little bit on language too, and then did fairly poorly on delayed recall, ultimately at a 17 out of 30 on her initial MoCA score. This is an MRI that was obtained by her clinical neurologist. So this is somebody who actually works at UCSD anyway. And these are axial cuts with a FLAIR MRI sequence. And this is fairly significant for very prominent right medial temporal lobe atrophy, which includes the anterior temporal cortex. If you go up a little bit, you see that there's atrophy of the orbital frontal cortex as well. Going up further, there's atrophy on the right side of the frontal lobe, and even the caudate has taken a bit of a hit. Also, as you see that lateral ventricle a little bit larger on the right side. So fairly prominent, right worse than left, frontal and temporal atrophy. And remember that this is a 66-year-old person that we're looking at also. So in the community, this was initially treated as a primary psychiatric syndrome, a bipolar variant that was treated with lithium. She did not do well on those things. Eventually was seen by UCSD neurology, where her diagnosis was revised to behavioral variant frontotemporal dementia, BVFTD. And she was enrolled in the ADRC study, and she completed one set of cognitive assessments, which are shown here. And again, pretty consistent with the MoCA scores, a DRS of 118 out of 144, which is fairly low. Did score a little bit out of range for the GDS scale for depression at that point as well. She did have CSF that was collected as part of that year one visit. And these are the Alzheimer's disease biomarkers run on the Lumi pulse assay, but they're normal. She had normal amyloid beta ratios. P-tau and T-tau are not terribly remarkable anyway.
She was able to get a 29 on C, 15 on home. Yeah,
BVFTD guys, man, they can do stuff. So her clinical course from there on out, over the next couple of years, she did develop more prominent memory loss, had problems remembering caregivers' names that she would see on a daily basis. She had developed some fairly severe insomnia, but thankfully this was able to be treated with quetiapine. She developed some issues with balance. About 3 years into her disease duration, this did result in occasional falls, one of which she had a high humerus fracture. It was non-operatively managed, it sounds like. There's not a great description of motor deficits at this time, so I can't really say exactly the etiology or if she was Parkinsonian or something like that, but she did develop frequent falls a little bit later on. Over the next couple of years, she gradually became more apathetic, less verbal, much less verbal output, eventually was transitioned to a skilled nursing facility 5 years into her disease duration. Over the next couple of years, she goes to the emergency room several times for recurrent urinary tract infections, COVID infections at least twice, and sort of a stepwise decline after these subsequent infections. Transitioned to hospice care, and she eventually passed after approximately 7 years of her disease course, and she was age 71 at the time. This was a follow-up MRI that was done on the clinical side anyway. This was 5 years into her disease duration, 2 years prior to her passing, and you can see that there's fairly prominent worsening of the atrophy with both sides getting hit now, still right much worse than left, but both temporal lobes, both frontal lobes being particularly hit, with subcortical structures being affected as well, like the subthalamic nucleus and the caudate heads especially. Want to talk about BVFTD, just in case you like clashing colors anyway. So, BVFTD, starting down here anyway, there's a lot of different pathologies that can result in a behavioral variant FTD sort of phenotype. And the split is largely between FTLD tau type things and FTLD TDP43 type etiologies. Many people with FTLD TDP43 will also have ALS type issues as well. And on the tau side, you can go up anyway. We often see these sort into, progressive supranuclear palsy or cortical basal degeneration, which often ends up in movement disorders clinic. Pick's disease, which is a 3R tauopathy, which is mostly a BVFTD type presentation, and a couple of other things that are more rare anyway. But the split is pretty 50-50, with a smaller percentage in the middle anyway, who might have an atypical frontal Alzheimer's variant. And the also kind of difficult figure at the right is a case series from UCSF's brain bank, where they had assembled 117 cases who were clinically diagnosed with BVFTD and what neuropathologies did they actually have at autopsy. And you see this kind of split with tau being the red and orange guys, TDP43 etiologies being these sort of cool colors, blue and purple anyway, and then a little bit of Alzheimer's for about 1/8 of the cases, and then kind of unusual things creating the minority. But it's a very pathologically heterogeneous, like underpinning lots of different things that can present with fairly similar symptoms. Now, we didn't get any hints, so to speak, like there wasn't much in the record that would indicate that this person maybe had, say, PSP or CBD. We didn't hear anything besides falls, but there was no description of Parkinsonism, eye movement changes, particular language perturbations, apraxia, dystonia, myoclonus, these things that would normally help us a little bit anyway. This seems from the record like a fairly pure BVFTD syndrome. Case 2. Yes, we're doing 2 cases today, but they're do. So This is a 76-year-old man who originally entered the ADRC study as a healthy control. He got involved with the study because he had a spouse with memory impairment who was also enrolled anyway. Um, Maybe 2 years into the study, he maybe became a little bit more forgetful, lost track of a couple of scheduled social events, maybe a little bit of trouble recalling like names of actors and movies that he had seen a while ago, or maybe extended relations. It would take a little while to come back to him. But that was kind of it. He still maintained his own finances. He still drove without issue. He was the primary caregiver for his spouse. Um, his daughter, who was the corroborating source of history for the visits, didn't notice any significant cognitive decline, although depression had been a concern because it was very difficult to take care of his wife as she got sicker. He had a fairly significant cardiac history with a multi-vessel cabbage and hypertension, hyperlipidemia. He used to work for the Navy, and then subsequently, after retiring for there, worked for the U.S. Postal Service for a time. There's no family history of any other dementing illnesses. So he had been enrolled in the ADRC over 6 years. One year visit was missed because of the pandemic anyway. And you can see that he performs fairly well, like throughout his course anyway, with decently high and stable scores on the MMSE and the DRS especially anyway. He does pretty well actually on short and long delayed recall, even at year 6 anyway, really performing at Z scores of 0 for his age-adjusted performance. His diagnosis kind of wobbles a little bit anyway, from having normal cognition to having some variant of mild cognitive impairment anyway, and sort of one of the middle columns anyway, but pretty stable cognition throughout the study. He did have spinal fluid that was sampled upon enrollment. The A beta 42 to 40 ratio is just a touch low anyway, but the other ratios were largely unremarkable anyway. So we have those Alzheimer's biomarkers on him. Now, he did not get his clinical care as part of UCSD or any other healthcare system that we were able to abstract any other clinical variables for. Unfortunately, I could tell that he started having frequent falls. Again, etiology kind of unclear. Some of them sounded mechanical, falling over when reaching for things. Some could have been related to hypotension, low blood pressure anyway. And one of them did end up with a small subdural hematoma. It didn't have to be evacuated. It was only 3 to 4 millimeters, it looks like, on the record. 2 years after the last ADRC evaluation, he got admitted to a local hospital in the community with nausea and vomiting, was found to have a UTI and subsequently very bad aspiration pneumonia, protracted ICU stay, was ultimately discharged and pretty rough shape to a long-term care facility, and eventually passes 2 months later after this kind of acute and prolonged sepsis hospitalization anyway. I don't have any pictures to show you on any brain scans because we can't get at them anyway, because it was, different healthcare system. But, kind of interestingly enough, I did want to talk a little bit about the literature as it relates to the neuropathology of basically cognitively normal older participants anyway. These are a little bit harder studies to do because a lot of these, studies, including ours anyways, focus on specific diseases, but there are some community-based programs that have autopsy brain donation services, and some of them are listed here. And the figure up here is really sort of a harmonization effort that happened with the Lancet Health Longevity Study from 2023, looking at all of these sort of large ones, ROSMAP, the Honolulu Asia Aging Society, Adult Changes in Thought Study. They tried to put all of this together. Now, these studies have been going on for quite a while. Pathology methods have changed over the years anyway. So the first thing we wanted to mention is that this is an upset plot where they're looking at combinations of different pathologies anyway. I guess you want to look at these rows to see they're looking at severe neuritic plaque pathology, high Brock stage tangles, the presence of micro or macro infarcts, any degree of Lewy body pathology, or late TDP pathology that extends beyond the amygdala. So just, I guess, a point anyway is that this is going to miss like low level, small amounts of neurofibrillary tangle pathology or mild amounts of amyloid pathology potentially. But in so much as, for people who don't have any of these more severe forms of pathology, a fair amount of them will not have dementia when they pass away. A couple other notes from this figure, there's just a lot of information here, is that most people have more than one pathology when they pass away. As you get 2, 3, 4, 5, 6 amounts of co-pathologies or mixed pathologies, you're less likely to be pink. You're less likely to have no dementia when you pass away. But there are certainly people with single pathologies, some with a fairly decent proportion of them who will have no dementia when they pass away. Maybe the greatest proportion, at least in this graph, would be for the single pathology of people who have neuritic amyloid plaques anyway, with more than 50% of them having no dementia when they pass. And I think that tracks with what we know about amyloid and tau and their relationships to cognitive impairment anyway. So that is sort of like a cross section of data at autopsy anyway, but if you kind of cut this up by age as well, what you generally see, and this is from the CFAS study anyway, is that if you are, say, 70 and you have a fair amount of neuritic plaque pathology anyway, you're more likely to be demented at 70. But if you live to 100, for example, anyway, live to 100, you can still have a fair amount of pathology if you're living to that amount and still be non-demented, it seems like anyway. And this is not only borne out in the pathology literature, but also in CSF and PET studies too. We see fairly similar looking curves. So if you have Alzheimer's or dementia at a younger age anyway, you're very much likely to have these abnormal biomarkers. But if you're cognitively normal, older and older, you still can harbor these pathologies anyway too. So this person had passed away at age 84 anyway. And a lot of this literature, again, is focused on Alzheimer's disease anyway, being the most common. Less is known about other things besides Alzheimer's pathology in the space anyway. And does anybody have questions about these two cases before we move on to the pathology? So as a reminder, we have one BVFTD and one pretty cognitively normal guy anyway. He was mentioned as MCI language at his year 6 anyway, although I didn't see a lot of he got a 21 out of 32 on the mint. Okay. So we're saying MCI language. That's how he bought himself MCI language at this point anyway. And sorry for Zoom people, Dr. Salmon was pointing out that a mint of 21 out of 32 is at least mild impairment. And then the year 4 and year 5 that he didn't do that well on some of these animal testings anyway. So that's why he had earned himself an MCI language designation at this point, it looks like.
Just the dizziness on that first lady.
The falls, the lady who, yeah. Yeah, it's a little tricky. There's physical exams in the chart, but they don't mention gait disturbances. They don't mention Parkinsonism or shuffling or freezing. Doesn't mention orthostatic hypotension, some of the things that we, run through when we're worried about falls. And
yes.
And sorry, also, I'm missing a slide here somehow. For case 1, I did want to mention that this person had obtained a master's degree anyway, and socially had worked for a number of different dialysis companies over the year and actually taught at a local college, renal nutrition anyway. And there was also no family history of other dementing illnesses in her family. And she actually didn't have any other medical problems anyway. She was medically normal up until all of this started happening. Shall we go on to path then? Get you here, guys. There you go.
All right, so before I jump into case 1, just for any trainees in the audience, I'll go a little bit over what we're kind of looking for in every case when we look at these brains from the ADRC. And as a reminder too, half of the brain, the right half of the brain is typically frozen for future research, and the left half of the brain is what I receive in formalin to examine for these pathologies. So of course, it's the ADRC, right? We're going to look for Alzheimer's disease, even in that FTD case, the first case, as Dave showed, about an eighth of those could be attributable to Alzheimer's. So we'll investigate that. And for Alzheimer's, we're looking for tau tangles and amyloid plaques. So this is an H&E of a neurodegenerative brain. There's neuron loss and gliosis. This is a reactive astrocyte in this circle, and a nice neurofibrillary tangle in by the arrow, which would be positive with a tau stain. And then we're going to look for plaques, right? So beta amyloid stain, this has a lot of diffuse plaques in this brain, and you can also see there's a little bit of amyloid angiopathy. We always look for Lewy body pathology. So this is a nice example of Parkinson's disease where we have a pale substantia nigra. You can see the Lewy bodies as these eosinophilic rounded cytoplasmic inclusions that are peripherally haloed and would be positive for alpha-synuclein staining. But we don't just look in the substantia nigra. We also look in the limbic system. So we'll look in the amygdala and the cingulate gyrus, as well as the temporal cortex to look for more diffuse Lewy body pathology. And then, of course, for the first case, we're very interested in our differential for frontotemporal lobar degeneration. So as Dave kind of talked about, we divide these based on which protein is accumulating abnormally. So there are FTLD taus, which is quite the list there. And then we have FTLD not tau. The biggest group of that would be FTLD TDP43. And then there's some others that you can group as FTLD-U, which is for ubiquitin. So within the tau, you can divide that further. Is it 4 repeat or 3 repeat tau? The big ones for 4 repeat being CBD and PSP, and then the classic 3R frontotemporal lobar degeneration would be Pick's disease. So we will look for all of those with our tau stains, and then we also do TDP43 stains to look for FTLD TDP43 as well as late, which could be pertinent in the second patient who is a little older. And this is just a breakdown of the tauopathies, again, showing you some examples of what the different pathology can look like in these 3R versus 4R tauopathies. So Pick bodies, you could see, would be 3R positive, and there are more of these spherical inclusions in neurons, versus the 4R tau, you're really looking at the morphology. So there's igyrophilic grain disease, there's globular inclusions in globular glial tauopathy, and then CBD and PSP get a little confusing because the astrocytic plaques and the tufted astrocytes overlap a little bit in their morphology, but those would also be 4R positive. So these are the kinds of things we're looking for in that first case. So again, remember, this is the patient's left hemibrain. It looked like on imaging, the right would probably be quite a bit worse. But you can see I have peeled back the leptomeninges from the hemisphere, and there's some atrophy in the frontotemporal, maybe the parietal lobe. I actually think it looks worse from this medial view. The parasagittal cortex looks quite atrophied here, and you get a hint that maybe the ventricle is going to be quite enlarged. And here are the coronal sections. So we do have hydrocephalus ex vacuo. So this lateral ventricle is large and rounded. This should have a nice narrow angle in a normal brain. There's also enlargement of the temporal horn, maybe some mild hippocampal atrophy, but not bad. Again, it might have been worse on the right. And I did note, it's not that obvious in these pictures, but I did note on my gross examination that the corpus callosum seemed a little thin in some regions. And the substantia nigra was overall pretty well pigmented. So then we go to our histology. We'll start with our H&Es. So this is a section from the middle frontal cortex. On the left is gray matter, and on the right is the underlying white matter. The gray matter, no obvious neuron loss or gliosis really jumping out at you. But on the white matter, it looks pretty rarefied, kind of pale. There's some widened perivascular spaces, but it looks, pretty unhappy white matter. And this is a picture from the entorhinal cortex. So we always look in the entorhinal cortex in neuron clusters of layer 2 for neurofibrillary tangles, which is one of the first places that you're going to see them in Alzheimer's disease. So this is one cluster, and there does appear to be some neuron loss. So these larger cells here are the remaining neurons. There's maybe a few reactive astrocytes with pink cytoplasm. I couldn't on H&E immediately see tangles there, which sometimes in a really bad AD case, I can pick up big clusters of tangles, but that's oftentimes you need to do the tau stain to really appreciate them. There may be ghost tangles in this region. So we'll be definitely interested in looking at that based on this neuron loss. This is the posterior hippocampus. This is a very low power view. So you can see the dentate here and then CA4, 3, 2, and 1. These little purple dots here, that's just mineralization of blood vessels in the molecular layer of the hippocampus, which is a common thing we see with aging. But overall, hippocampus didn't look too bad at low power, but you zoom in on CA1 and there's pretty severe neuron dropout. So there's a few neurons remaining, but most of this is kind of rarefied parenchyma with reactive astrocytes, these pink cells here. So quite a bit of neuron loss. Although despite that, usually when I see this much neuron loss, I can kind of scroll around through the other regions of the hippocampus and find a lot of tangles if it's a straightforward AD case, but I was not readily finding tangles on the H&E. And then we look at the substantia nigra, again, looks pretty well pigmented. There's a little bit of extraneural neuromelanin, so this brown pigment that's kind of outside of the cytoplasm of neurons, which suggests maybe there's some minor neuron loss, but I did not see any Lewy bodies or anything else in the substantia nigra.
I asked something on those past couple. This one also.
This one, yeah.
And then is that vacuolation or not?
Yeah, I like to use the word rarefaction. It does look a little vacuolated, kind of pale. Some of that you have to be careful because we get a little bit of vacuolization from, postmortem artifact. The longer the interval, the more kind of vacuolization we'll get. But yeah, it does look a little vacuolated. So then we'll look at amyloid as our first IHC. So you can see here the amyloid, which usually starts out in the cortex in Alzheimer's disease. It's completely negative in the middle frontal cortex. This is just a control to show you that the stain did work. And we also did not see amyloid in the entorhinal cortex, the basal ganglia, the midbrain, or the cerebellum. So no amyloid to be seen. And based on that, we stage our amyloid distribution using the Thal phase. And so this would get a Thal phase of 0 because there's no amyloid. So then we want to look for tangles. So we're going to look at our tau stains. And this is a tau in the entorhinal cortex. So remember, we're looking at those neuron clusters in layer 2, which I thought looked somewhat depopulated and gliotic. There's maybe a few tangles here. There's a lot of tau kind of positive thread-like staining in the background. And then there's this weird kind of globular staining that doesn't look like a nice straightforward tangle. So we'll kind of keep that in mind. But then I looked at the white matter underlying the entorhinal cortex, so the temporal lobe white matter, and this tau staining was actually much worse when you compare the gray matter to the white matter. So there's all these threads in the background, and then there's these kind of globules of staining that are varying in size, and it looks like it's affecting glial cells more than actually the neurons in the overlying gray matter. And we also saw similar staining in the frontal cortex. So this is the middle frontal gyrus. This is out in the gray matter, again, this thread-like staining, and then these weird globules, but not really well-formed flame-shaped tangles like you would expect in Alzheimer's disease. So we don't have amyloid, we do have tau, but it doesn't look like your typical neurofibrillary tangles. So it doesn't look like we're dealing with Alzheimer's disease in this case. Are we dealing with one of these tau-positive frontotemporal lobar degenerations? Again, those can be divided into 4-repeat or 3-repeat type diseases, a few of which have overlap with both isoforms. So we actually have stains we can do to look at 4-repeat and 3-repeat tau, as well as a GT38, which is an Alzheimer's specific type tau. So this is the GT38, which should only be positive in like true Alzheimer's disease type pathology. And this is the entorhinal cortex. And you can see we do have a few tangles, but it's not much. For a really bad Alzheimer's disease, you would expect just like seas of tangles in the entorhinal cortex. And all of those little globules and threads that we saw staining on just the general tau stain are not lighting up with this Alzheimer's disease specific tau stain. And all that tau that we saw in the middle frontal cortex is completely negative with the GT38. So not looking like much Alzheimer's tau type pathology. So then I did the 3 repeat and 4 repeat tau. So the 3 is on the left, 4 is on the right. This is the entorhinal cortex. Again, there's some 3 repeat. That's probably Alzheimer's disease has 3 and 4. So it looks like it's staining some of those Alzheimer's disease type tangles. But all of that more kind of globular and thready staining is positive for the 4 repeat tau. And then we look at the temporal lobe white matter, and the distinction is very clear. So there's pretty much no 3 repeat tau in the white matter, and all of that globular staining is very positive for our 4R tau. And this is just a higher power view, so you can really see the morphology of these is very strange. These variably sized kind of globules, they're not tangles, and the variation in size is quite distinct, and you'll see that compared to our second case as well. And then this is the middle frontal gyrus. So again, pretty much no 3R tau. The 4R tau at the top of the field, this is in the gray matter. So there is some tau, but it is actually worse in the white matter, which is about from here on down. So again, it looks like it's maybe more of these globules are in the glia within the white matter, as well as in the overlying cortex. Yes, specifically. And so we think we are in this group of 4R frontotemporal lobar degeneration pathology, which gives us kind of multiple choice. So cortical basal degeneration, progressive supranuclear palsy, a gyrophilic grain disease, and globular glial tauopathy. And so we can go back to our picture and, the grains have a more uniform size and a bit of a different distribution. So it didn't look like a gyrophilic grain disease. It did look pretty globular, and it's specifically affecting, as you said, oligodendroglia and more in the white matter. And so that fits very well with globular glial tauopathy. We did not see the astrocytic plaques or the tufted astrocytes typical of CBD or PSP. So we thought this fit pretty well with globular glial tauopathy, which was our final diagnosis and is a category of FTLD tau. All right, so the second case, this is the patient with kind of mild cognitive impairment, older patient 84. So his brain weighed, the hemibrain weighed 584 grams, which is about 1168 grams for the total weight. So a little light. We like to see like 1200 to 1400 depending on height, and maybe minimal cortical atrophy, but overall it looks better than the brain we saw in case 1. Particularly from this medial view. You will notice there's this little kind of brown lesion in the base of the pons, and that's just a little vascular lesion that's kind of an incidental finding. We didn't find it clinically noted in the limited clinical history we had. They probably would have picked it up though, because he did have imaging outside. They would have picked it up, but it was not like clinically significant.
I only saw CAT scans from outside.
Oh, okay, no MRI.
I had no MRIs. Do you think this would have shown up on a
Yeah,
CAT
I don't
scan?
know. Maybe only on MRI, yeah. And then here are his cross sections. So you can see when looking at the lateral ventricle, much smaller ventricles than the last case, right? So look pretty normal in size. His hippocampus, again, doesn't look like there's any severe atrophy here. The ventricle is smaller in the temporal horn. So overall, looks pretty good, particularly for age 84. And that's just a higher up view of this little vascular malformation in the base of the pons. And so this is a section from his frontal cortex. Again, left is gray matter, right is white matter. And again, gray matter looks pretty good. There's a little bit of postmortem artifact, some of the spaces around the vessels and the neurons. But the white matter, you see how much pinker it is than the last case? It doesn't look rarefied or gliotic. So his white matter looked good. And here's his entorhinal cortex. So again, we have a neuron cluster in layer 2. It's a little better populated than the last case. We can pick up some large neurons. I wasn't readily identifying neurofibrillary tangles, but wouldn't be surprised to find a few in there, particularly at age 84. Here's a low power view of his hippocampus. Again, looks pretty good. No obvious atrophy from low power. And we go to high power, and this is in CA1 in the posterior hippocampus. Very well populated, nice neurons, no tangles. I think maybe I saw a bit of granulovacuolar degeneration, but that's kind of at 84, probably just a normal aging change. His substantia nigra, there's maybe a little bit of dropout, again, with some extraneural neuromelanin and a bit of vacuolization, but I did not find any Lewy bodies, including on synuclein staining. So it didn't look like he had Lewy body disease. So he has mild cognitive impairment clinically, maybe a bit of dropout in the entorhinal cortex. Hippocampus overall looked okay. Are we going to see some like early Alzheimer's disease type changes? So first, again, we'll look at the amyloid. And he does have amyloid. So he has amyloid plaques in his middle frontal cortex. We also saw positive amyloid staining in the entorhinal cortex, basal ganglia, and there was just a few in the periaqueductal gray matter of the midbrain. But beta amyloid staining was negative in the cerebellum. So based on this amyloid staining going all the way down to this midbrain, this would get him a thal phase of 4, so pretty high, which would be an A3, so the highest you can score for thal on that. And then we look at tau. So this is entorhinal cortex. We have a few tangles, not a surprise, not a ton. But then we have weird staining again. So we have these little grains. They're not quite as large and globular as the last case, but there's all this kind of dot-like staining in the background. And this is just a higher power view to kind of show you these smaller inclusions. It also looks like in the entorhinal cortex here, there's kind of a pretangle, this neuron here with kind of this granular tau staining that hasn't quite formed a nice flame-shaped tangle yet. And we also saw, again, a few tangles in the hippocampus, but the more prominent staining was this little dot-like tau positivity, and maybe a pretangle down here as well. And it was most prominent in CA2, where again, we have all these dots, another pretangle, which is pretty typical for this pathology. And in the temporal lobe white matter, we don't see, you can see this is more affecting the gray matter of the hippocampus and the entorhinal cortex and less so the white matter, unlike our last case. Although there was some tau staining in the white matter, including this kind of coiled body, which is this kind of C-shaped inclusion within an oligodendrocyte. And just to add to his tau pathology, we always look for RTAG, aging-related tau astrogliopathy, which is often kind of subpial, perivascular, or subependymal. So we look for that in the amygdala and the frontal cortex, and you can see in his middle frontal gyrus, there is some subpial astrocytes here that are staining, so that he does have a little bit of RTAG pathology.
Which also would be like a CTE type thing.
No, it's just an aging. We see it all the time. The amount of AD cases I see it in is kind of unclear to me whether it's associated with any clinical symptoms, but it's not associated with head trauma like CTE. In this case, it does look, I see why you say that because it's kind of at the depth of the sulcus. But
The mix tau.
it's actually typically mostly 4R tau. And so based on, if you go back to this picture, the hippocampal staining, the entorhinal cortex staining with this grain-like staining, these pretangles, and also the coiled oligodendrocyte staining, this fits best with a gyrophilic grain disease. So we're still kind of in this 4R tauopathy group. And this patient did have, a little bit of Alzheimer's disease pathology, whether it was that or the grains causing his mild cognitive impairment or both. But really the AD type tau pathology was not very impressive despite how much amyloid he had. If you had to stage it, it would be a 2 or a 3, but when there's this overlapping tau, we can it's complicated to do the Brock staging. But I think I gave him just a 2 because there was very little in the entorhinal cortex and hippocampus. So then he would get like an intermediate ADNC score. And then this is just the lesion in the pons for anyone that wanted to follow up on our little vascular lesion. So it's all these dilated capillaries. There's no risk of hemorrhage with these or anything. So we just call these capillary telangiectasias. They're one of the incidental vascular lesions we see at brain autopsy. So we just noted that as part of his diagnosis. So he got a diagnosis of agyrophilic grain disease, aging-related tau astrogliopathy, which I didn't show, but was also in the amygdala as well as that area in the subpial portion of the frontal lobe. and a capillary telangiectasia in the pons. He does have amyloid and kind of an intermediate ADNC as well.
Was it not considering that capillary too much?
No, they actually don't really leak much. It's not like a cavernous malformation that will leak and cause seizures. It might not have seen it, particularly a CT. Yeah. So the theme of the day, why we decided to do 2 cases today instead of just one, was these were both 4R tauopathies that were, a bit of a surprise when I got the slides. And I personally had never seen a case of globular glial tauopathy or really agyrophilic grains for that matter.
They're supposed to be fairly rare.
Yeah.
They came in pretty close to each other, actually. Right?
Yeah. So I just want to compare so you can see side by side why I thought the morphology fit for each of these cases. So I think they're pretty good names. Globular glial tauopathy is these pretty globular, mostly oligodendroglial type inclusions that vary more in size and shape, versus the agyrophilic grains are this more uniform dot-like staining, grain-like staining. Did you want to? I can mention it, but you had so.
We were kind of trying to drive home sort of the theme of the day, which is these are sort of rare 4R tauopathies anyway, very different clinical presentations. And at least when you're thinking about sort of this hierarchical family-based structure anyway of, we want to group 4R tauopathies together anyway. And Vanessa already showed really nicely all of those great pictures of how the cellular morphology of where some of that pathology likes to live anyway within astrocytes, oligos, and even within the cells, like some of those more distal pathology that you'll see in cortical basal degeneration versus that which is a little bit more closer to the nucleus and like PSP, for example. But in addition to that, there's a fair amount of effort that's been worked on the E&M structure of these different tauopathy fibrils and everything. And there are some different protein folds that happen for each of these individual tauopathies anyway. And then they're grouped anyway here by the sort of a 3 repeat, with the Pick's disease fold being sort of the prototypical one. These sort of mix that you'll get in Alzheimer's disease and primary aging related tauopathy. But over on the other side is where you get your AGD type fold that actually has 4 layers of tau going through it anyway, versus your GGT type folds anyway, which actually has 3 layers going through it. And these are the protein structures of how these fibrils will line up for AGD and GGT anyway, if you look at this under electron microscopy. So similarities and differences.
Under or not.
Well, the first case, certainly.
The first case, certainly. The second case, not so much. I mean, there was mostly just involvement in the temporal lobe. I didn't really see much in the frontal cortex, and clinically, he was not really an FTD. So just a little more information about globular glial tauopathy, or GGT. So as you can see, there's some features that overlap clinically and pathologically with other 4R tauopathies. And our case presented as a behavioral variant frontotemporal dementia, which is one of the ways that GGT can present, but it can also present as motor neuron disease or with extrapyramidal features. And as you saw in our case, there's really severe involvement of oligodendrocytes, which results in white matter pallor, axon loss, and gliosis. So it's really like a white matter centric disease. And some of the early cases that were reported in the literature, it was so white matter centric and predominant, such impressive white matter loss, that they were terming these leukoencephalopathies. And there are different subtypes of GGT that have been reported in the literature. This is from the 2013 consensus recommendations for GGT. So there's 3 types kind of based on the distribution of these globular inclusions, which corresponds a little bit with the clinical features and the common clinical diagnoses. So if it's just frontotemporal, that would be type 1, where they have kind of frontal lobar features of FTLD and dementia, and these can commonly be diagnosed as frontotemporal dementia or Pick's disease. And then if it's in the motor cortex or the corticospinal tract, those can vary, but sometimes those can get diagnosed or overlap with PSP and CBD, as well as motor neuron disease. And then the third type has more diffuse involvement, can kind of overlap of both type 1 and type 2, where it has frontotemporal involvement and the motor involvement, and can have similar overlap. So just like Dave showed those charts where all of these diseases can kind of overlap clinically, and then you have to have a pretty broad differential when you're going and looking at the pathology. And this is just a nice example of a type 1 pathology where the white matter in the frontal lobe was really much more affected than the gray matter.
In the first case, we had, I don't think you showed us the flare, but was it, did they have some abnormality, white matter and flares?
For the first case?
First case.
There should be flare images up there. It didn't look terrible, actually. There wasn't a lot of hyperintensity in the white matter anyway. Or maybe I would look again because you're so struck by the atrophy, honestly, that would take another look. Sure, I guess.
And then a gyrophilic grain disease, or AGD, was first reported in 1987 by Brock and Brock. And it's interesting because Larry will tell me, like, back in the day, there was all of a sudden AGD was like the hot topic and everyone had a gyrophilic grain disease. But then I haven't really seen it that much in our Alzheimer's disease cases that I've been looking at. But in some reports, they report the prevalence as up to 9.3% in 65-year-olds and up to almost a third of centenarians. So in my experience, I haven't seen it that frequently, but in some reports, it's pretty common, actually. And the clinical can vary quite a bit. So it may have very slow, progressive, mild cognitive impairment, which kind of seems like what was going on maybe in our case. And they may have neuropsychiatric symptoms, including personality changes or emotional imbalance. There's been rare cases in the literature with features of FTD. And then this has also been reported in cognitively normal patients as well. And the three main histologic features of a gyrophilic grain disease are, of course, the grains, which are the dot-like staining in neurons. Then we have the oligodendroglial coiled bodies, which we saw in the white matter in our case, and then these neuronal pretangles. And a gyrophilic grain disease tends to particularly affect CA2, which was the case in our case too as well. And it may be seen in combination, of course, with AD type pathology. And there is staging, which I won't get into, but there's the cytostaging, which is basically stage 1, 2, or 3, depending on the distribution, which you can see here on the right. So it starts out kind of in the anterior hippocampal gyrus and kind of works its way back. At stage 3, it also involves the insula and the cingulate gyrus, so it can become quite more widespread. And then this was a table, again, from the 2013 consensus recommendations for the diagnosis of GGT, just showing these different 4-hour tauopathies and the specific pathological features that we see and whether or not they're present. And you don't have to look at everything in this chart. It's a little much, but basically the gist of it is there's a lot of overlap. So all of them, you can have some neuronal tau inclusions. All of them, you can have some oligodendroglial tau inclusions, but then it's what do those look like? So GGT, you don't typically see the coiled bodies, but you will see those in PSP, CBD, gyrophilic grain disease, and in these MAPT, FTLD hereditary forms. Versus the globular inclusions are much more characteristic of GGT. And then there's even some overlap with tufted astrocytes, which we typically see in PSP. You can see in some of these other entities, as well as astrocytic plaques, which are most characteristic of CBD. So you really have to look at everything and take the whole picture together to decide which of these fit best with the morphology.
So that is just wrapping up anyway. Today we presented to you 2 cases, one with a clinical BVFTD syndrome that was ultimately found to be due to GGT pathology, and a second one with mild, MCI issues that was ultimately found to be due to our gyrophilic grain disease. And these are both relatively rare for our tauopathies, so we wanted to present them both together.